Hello and welcome once again, my friends. My name is Dr. Syed Nair Kazmi. Welcome to my YouTube channel, and in today's video I'm going to talk about juvenile idiopathic arthritis. Juvenile idiopathic arthritis is an inflammatory condition of the joints which we see in children. So in today's lecture I'm going to talk about what is actually juvenile idiopathic arthritis, how do we diagnose it, what are the types of juvenile idiopathic arthritis, and how do we treat it. But before I start, for those of you who are watching my channel for the first time, please do subscribe to my channel. And if you like my videos, please press the like button, share it with your friends, and also comment. So without further ado, let's jump into our today's topic, and that is juvenile idiopathic arthritis. So as I said earlier, the juvenile idiopathic arthritis is an inflammatory condition of the joints in children, and by definition we call it an inflammatory condition of one or more joints in patients less than 16 years of age, where the duration of these inflammatory changes has been more than 6 weeks, and where you have excluded the other forms of arthritis like septic arthritis or traumatic arthritis, etc., etc. So once again, please keep it in mind that it is an inflammatory condition of one or more joints in patients less than 16 years of age, where the duration of the inflammatory changes is more than 6 weeks, and where you have excluded the other forms of arthritis. So these would be your pediatric population. They would be having a problem in one or more joints, like it could be 4, it could be 5, it could be more than that. And usually the duration of symptomatology is for more than 6 weeks, and this is one of the diagnostic criteria for JIA. And at the same time, you have excluded other forms of arthritis by doing tests, like you have already ruled out septic arthritis, you ruled out traumatic arthritis, etc., etc. So this is the definition of juvenile idiopathic arthritis. Now coming to the classification of the juvenile idiopathic arthritis. Now juvenile idiopathic arthritis is classified into many types. Some books classified it to 5 types. I think some of them have even further dissected the definition. They've gone even up to 7 types. But the 5 common types of juvenile idiopathic arthritis are number 1 is Oligoarticular JIA, or we also call it oligoarthritis. So it's a JIA where there are less than 4 joints involved. There is a polyarticular type of JIA where more than 4 joints are involved. There is the systemic onset JIA where usually one or more than one joint can be involved, but it's usually preceded with systemic symptomatology for some time. There is the undifferentiated juvenile idiopathic arthritis where things are not that very much clear. And then we have got the psoriatic arthritis, which is the arthritis associated with psoriatic changes on the skin as well on the nails. And last but not the least, we have got the enthesitis-related juvenile idiopathic arthritis, in which some of the ligaments, especially the sacroiliac joints and the back ligaments, they are inflamed. And there are a lot of issues with the back as well. So these are the 5 types. So I will go through them once again. So we've got the oligoarticular type, the polyarticular type, the systemic onset type, the undifferentiated type, the psoriatic type, and number 6, the enthesitis-related type. So there are 6 types. Sorry, I said 5 in the beginning. The 6. Some have gone a bit further and classified into 7 types as well. So there are 6 types of these classification of juvenile idiopathic arthritis. Now let's go through all of them one by one. Now, if we start with oligoarticular JIA, oligoarticular JIA is where, again, it has to fulfill the definition. The population would be less than 16 years of age, more than 1 joint would be involved. In this case, it simply means that it is more than 1, but it's less than 5. In other words, it's less than, it could be anywhere between 1 to 4 joints which are involved. And usually we have seen that the oligoarticular type is more common in females as compared to males. And there are again 2 types. It could be a persistent oligoarticular type of JIA, where let's say 2 or 3 joints are involved, and then they remain affected in the future course of illness. They do not progress into, like, the disease does not progress to other joints. There is another type as well, which is called the extended oligoarticular type of GIA, in which it starts with less than 4 joints in the first 6 weeks, and after that it spreads and more joints are involved. So a persistent oligoarticular arthritis or type of oligoarticular GIA, and the extended oligoarthritis type of the oligoarticular JIA. So remember, in this particular type, 1 to 4 joints can be involved. It usually involves the female. It usually involves the lower extremity joints, like the knee joints, both ankle joints, both hip joints. Important thing in oligoarticular JIA is that if somebody is fulfilling the criteria for oligoarticular, that they've got 2 or 3 joints involved, it's been more than 6 weeks, you have excluded other types, then it's very important, and it's usually exam question as well, that what should you do after that. There are 2 things. You have to do an ANA screening test. ANA stands for anti-nuclear autoantibodies test. So you have to look at their ANA status. And if the ANA status is positive, it's very important that they've got 6 monthly to yearly slit eye examination, because anterior uveitis is very common in this type of arthritis, GIA, and it can lead to blindness if not treated or detected in early phases of the illness. So this is oligoarticular GIA, in which I told you that less than 5 joints are involved. So it could be anywhere between 1 to 4 joint. And I told you that it's usually the large joints are involved. It usually occurs in the lower extremities and more common in females. Then we have got the polyarticular type. The polyarticular type is the condition in which more than 4 joints are involved. So 5, 6, 7, 8 joints can be involved. Now, in this condition, usually the small joints are involved as compared to the oligoarticular type, where the bigger joints are involved. So, but obviously, because the number of joints is more, you will see there will be a mix of large and small joint involvement. Again, the definition, again, you have to fulfill the criteria for that. The population, the age should be less than 16 years. There should be more than 4 joint involvement. Again, more than 6 weeks duration, and you have excluded other forms of arthritis. Now, in contrast to oligoarticular form, here the screening test that we use is the rheumatoid factor status. It's very important that for polyarticular type, you do the RF status, rheumatoid factor status, and the rheumatoid arthritis or rheumatoid arthritis factor, as we call it. Some call it the RA factor, RF factor, whatever you call it. But anyhow, that is the next screening step if you are putting a child in the bracket of polyarticular GIA. Because you have to see whether they are RF positive or RF negative. If they've got RF positive, usually that is quite an aggressive illness, and it goes on, even it becomes the adult form of rheumatoid arthritis. Comparatively, RF negative polyarticular form of GIA has got a bit better prognosis as compared to the RF positive. So again, please keep it in mind that if you are confronted with the polyarticular type, the next step would be to do an RF status and see if that is positive or negative. Then the third category is what we call as a systemic onset juvenile idiopathic arthritis. Now again, by definition, it is arthritis in more than 1 joint, which is usually preceded by high temperature, fever for at least 2-week durations. That has to be documented. It has to be a daily temperature for at least 3 days, and it should be accompanied by at least more than one of the following criteria. That is, there should be an erythematous rash, Solomon pink rash. There should be lymph node enlargement, usually cervical lymph node enlargement, but there could be lymph node enlargement anywhere. Hepatosplenomegaly, or just hepatomegaly or splenomegaly, and some form of serositis like pleuritis or pericarditis. So remember, it is 1 or more than 1 joint involvement, but before that joint is involved, there should be a history of fever for 2 weeks with daily spikes. So usually these kids have got a history where the temperature is spiking every evening with the appearance of a Solomon pink rash temperature touching up to 39, sometimes 40 degree, then coming down later in the evening. Usually responds to paracetamol or ibuprofen. It goes on for 2 weeks. They usually have got courses of antibiotics for different reasons. Doesn't respond to that. And usually after 2-3 weeks, one of the joint is involved. They develop joint pains, joint swelling, and at the same time, they would have either lymph node enlargement. I told you they might have a erythematous rash. They might have hepatosplenomegaly or serositis in the form of pleuritis or pericarditis. But any one of them, if that is present, that is enough to diagnose the child as a case of systemic onset JIA. It's very important if you are diagnosing somebody with the systemic onset JIA, you should do the LFTs to see if they are raised. You should do ECG to see if there are any signs of pericarditis, and also do a chest X-ray to see if you find any form of serositis. Anyhow, so this is the systemic onset JIA, juvenile idiopathic arthritis. Then we've got the psoriatic type of juvenile idiopathic arthritis, in which there are psoriatic changes, more psoriatic changes on the digits and on the nails. So usually they've got deformities in the form of sausage digits. They are usually, if you do the rheumatoid factor, they are rheumatoid factor negative. And it's quite a mutilatory arthritis, especially of the interphalangeal joint. So there is a lot of erosions if you do x-rays, and that leads to deformity and then contractures in the joint and destruction of the nail pad, and nails are destroyed. So that are the features of psoriatic arthritis. We also have got the enthesitis-related arthritis. I will come to that in a moment. Just before I go into enthesitis-related arthritis, just to give you, to summarize these important 4 types, that you've got the oligoarticular, you've got the polyarticular, and you've got the systemic onset JIA along with psoriatic. These are more common as compared to the enthesitis-related arthritis. So keep it in mind. The systemic onset JIA, usually the age group in the pediatric population is around 2 to 4 years of age, where it usually has got the onset. Male to female ratio is 1:1, and it starts with 2 weeks of spiking temperatures, daily temperatures, with the salmon pink colored rash, and then different joints are involved. Usually these are knees, wrists, and ankles, but it can also affect the finger joints and hip joints. So this is important things that you must keep it in mind regarding systemic onset JIA. Regarding oligoarticular JIA, it's usually the onset is around, it's usually less than 6 years of age when it onset. The female are more affected as compared to the males. It's usually 4:1 female to male ratio. Mostly these are the lower limb joints, large joints, knees, ankles, but sometimes the fingers can also be involved. And again, keep it in mind that you have to do ANA, and if ANA is positive, you have to do an annual or 6-monthly slit lamp eye examination, because 30% of these cases are associated with uveitis and scleritis, which if not detected and not treated can lead to blindness. Then we've got the polyarticular JIA, which again can be of 2 types, RF negative and RF positive, and more than 5 joints are involved. Uveitis is a bit rare in the RF negative form, only affects 10% of the cases. RF positive has got more aggressive course. It usually progresses to the adult type of rheumatoid arthritis, and the psoriatic arthritis is associated with psoriatic changes, and it's usually the small joints of the fingers that are involved. Uveitis is seen rarely in around 5 to 10% of these cases, but psoriatic skin changes are usually seen in more than 50% of these cases. Now, moving on to the enthesitis-related arthritis. Now, enthesitis-related arthritis, usually what happens is that the ligaments are involved, especially the back ligament. So sacroiliac joint is usually involved. So important thing in enthesitis-related is there will be a history of back pain, or what you call tenderness in the lumbosacral region. Usually these cases are HLA-P27 antigen positive. So they are males, usually greater than 6 years of age. HLA-P27 status is positive. They've got a very high incidence of acute anterior uveitis, again, which can lead to blindness.
And there are usually associated with other inflammatory conditions as well, like they can be associated with Crohn's disease, they can be associated with Reiter syndrome, or they might have a history of these things in their first degree relatives. So in enthesitis-related juvenile idiopathic arthritis, keep it in mind that usually it involves the back, so there is sacroiliac joint involvement along with other inflammatory condition which might be or might not be present in that particular affected patient. Also keep it in mind that as the course progresses, usually there's more and more inflammation, and that can lead to pain, that can lead to swelling, that can lead to difficulty in walking, difficulty in performing daily activities. And that is one of the reasons that most of them would present to their primary care physicians, or even being referred to a rheumatologist or pediatricians, because the course is progressing or has got remissions and exacerbation where you treat them, they are fine for some period of time, and then again it would deteriorate again, and they would be back to square one. One of the important complications that can happen in this chronic condition, juvenile idiopathic arthritis, is that sometimes, rarely, it can lead to a condition which is known as macrophage activation syndrome. And macrophage activation syndrome is a condition in which the macrophages are activated. The immune system goes haywire, the macrophages are activated, and a whole cascade of inflammatory cytokines and inflammation is started, which leads to widespread damage and tissue damage and changes in certain parameters which can sometimes be fatal. So usually in macrophage activation syndrome, there is a criteria. The liver enzymes are elevated, you have got a high ferritin level. Please keep it in mind that you need to have a high ferritin level, around more than 650 nanogram per mil, which is the criteria for diagnosing somebody with macrophage activation syndrome. So you have got raised liver enzymes, you've got raised triglycerides and raised ferritin associated with low fibrinogen and low thrombocytes. So there would be thrombocytopenia, there would be low fibrinogen, and increased in inflammatory markers including ferritin, liver enzymes, and triglycerides. So in a backdrop of juvenile idiopathic arthritis, somebody comes with severe deterioration in bodily function associated with these laboratory parameters. The diagnosis is macrophage activation syndrome, and if not treated properly with steroids, it can be fatal. As I told you, diagnosis is clinical, that you have to, the patient has to fulfill the diagnostic criteria, which I told you earlier. The next steps are usually depending on whether it's oligoarticular, the polyarticular. So you would be doing certain screening tests like ANA, you would be looking at their inflammatory markers, CRP, ESR. You would be doing joint x-rays to see the extent of erosions and joint damage. Sometimes even arthroscopy might be needed to sample the joint fluid and see what's inside, because you might have to exclude other forms of arthritis like gouty arthritis and so on and so forth. As far as treatment is concerned, yes, one thing more before I start on treatment, slit lamp examination for oligoarticular type is very important, and back x-rays if you are suspecting enthesitis-related GIA. Treatment are usually, the first line treatment are painkillers, anti-inflammatory drugs. So ibuprofen, aspirin is usually indicated in these conditions. High doses have to be started to in the beginning to control the inflammation, and then they have to be put on some maintenance dose of these anti-inflammatory conditions to keep the inflammation under control. But we have seen that these drugs are not very effective in controlling inflammation. They are good in controlling some symptoms, but they're not good in controlling the progression of inflammation. So the disease modifying drugs have to be used. And again, there are different types of drugs which are used. Different trusts have got different guidelines, and it's better to adhere to the guidelines. But some of the drugs which are mentioned in the textbooks are used are methotrexate. So methotrexate can be weekly used for that. Back in old days, D-penicillamine was also used, and it's not discarded because of its side effects. So methotrexate is one drug which is still used, and then we have got some other disease modifying drugs which can be used to control the progression of inflammation. These days, there is more focus on monoclonal antibodies, and monoclonal antibodies are quite good in suppressing the immune response, and the specific antibodies which are destroying the synovial membrane of the joints. And we have seen that people have almost normal life by use of monoclonal antibodies. So, but they are quite expensive. They have to be prescribed by rheumatologist, and they have to be given under close supervision. And once they've started on that, certain parameters needs to be checked again and again, because some of the monoclonal antibodies can cause reactivation of tuberculosis, or can make a child more prone to certain other types of opportunistic infections. So that's why it's very important to keep them under close supervision and do regular testing and checkups to see that they are not developing something else. So this was a brief lecture on juvenile idiopathic arthritis, its types, its diagnosis, diagnostic criteria, as well as treatment. So if you have liked my lecture, please do press the like button. And as I told you earlier, if you haven't subscribed till now, please do subscribe, as it helps. And if you've got any questions or comments, you can put it down in the comment section below. Thank you very much and have a good day. Bye-bye.